Thank you, Jill. Thank you to the organizers of this amazing day, and it's an honor to be here to talk to you about optimizing surgical management in the acromegaly disease. These are my disclosures. So as an overview, we're going to talk about the importance of surgery in acromegaly, the mainstay surgical approach, the transsphenoidal surgery, but you'll see more videos to come by Dr. Smith following this talk. We'll talk about remission outcomes with surgery. We'll talk about surgery for giant and invasive tumors and the role that plays in a multimodal approach towards remission. And then we'll talk a bit about the volume outcome effect. So we'll start with a case, a 42-year-old male who was otherwise healthy, but he'd been having some paresthesias leading to a brain MRI. Now, the paresthesias resolved after he had received B12, but then on further history taking, he acknowledged that yes, he'd had increased size of his hands and feet, he'd had worsening fatigue, brain fog, depressed mood, and increase in headaches. And in a full pituitary workup, the only abnormal finding was an elevated IGF-1 of a 712. And the pituitary MRI showed this macroadenoma in the cella with suprasellar extension and a little bit of compression of the optic chiasm here. So I offered him a transsphenoidal surgery as a first-line step for his acromegaly. And at 6 weeks afterward, he had an MRI showing no obvious remaining tumor. His headaches had resolved, mental clarity improved, mood improved, IGF-1 was normal. He was happy, and so were we as his treatment team. So treatment options in acromegaly, surgery is first-line therapy. It's it's a very powerful option to leading to remission and sometimes the only step towards remission. But as you've heard about, we have medical therapy to help us as well and various options to get us to remission with medical therapy. And of course, radiation therapy as an option as well. So all of these are the components of what the multimodal therapies we use for remission or normal IGF-1. And what's the goal of all these treatments? What's the goal of a normal IGF-1? Lowering patient mortality, lowering cardiovascular risk of cardiomyopathy, hypertension, allowing for diabetes control, and decreasing risk of long-term neoplasm. It's also a huge improvement in survival. So patients with uncontrolled acromegaly have a standardized mortality ratio that's high, 1.5 to 2, until biochemical control is achieved. On the bottom left, this is a Swedish group, a registry of their patients, and it shows the survival curve of those who are controlled as significantly improved compared to patients with acromegaly who were not controlled. And then on the bottom right, a decades-long paper by my colleague, Dr. Swearingen, but the first to report that in 84 patients who were cured with a surgery, their overall survival met the normal US population. So what is the transsphenoidal surgery? Well, it's the most direct approach, and we go all through the nose, no scars on the face, no swelling or outward signs of surgery. We use the endoscope, although the microscope was used for decades and still used by some. And we use intraoperative MRI in select cases. So here's a schematic of a cartoon of where we're headed, and you'll see again in more detail in videos. But and then in our ORs, we have an intraop MRI that will come out behind doors while the patient's still asleep that we can use in certain cases where we feel that it will be very valuable to know if there's remaining tumor before we say that the surgery is done. And so high volume surgeon is critical for these cases, and I'll go into more detail on that later in the talk. And our patients generally go home on post-op day 1 with outpatient hormone monitoring, managed with our team, our neuroendocrinology team, our nursing team, our endocrinologists. So this is the microscopic approach for transsphenoidal. It's where the light is shown through a nasal speculum in the nostril. This is my colleague, Dr. Brooke Swearingen, performing the microscopic technique for transsphenoidal. And then there's the endoscopic endonasal approach as well. And so that's where you work with an ENT colleague, typically a rhinologist who's fellowship trained, who places the endoscope into the actual sphenoid sinus and gives you into the cella after the tumor is removed to get a visualization up close of all the anatomy and the tumor. And it's just awesome to work as part of a team in the OR. They're great colleagues. So for surgical management, we always mandate a transthoracic echocardiogram prior to the OR to make sure that the patient doesn't have any significant cardiomyopathy, in which case we sometimes favor optimizing that prior to OR. And then an airway assessment. Are they safe to undergo intubation and a sleep intubation? Sometimes we favor fiber optic intubations, even awake intubations if necessary for patient safety. Post-op, these surgeries are generally very well tolerated and safe. So this is just some percentages from our center: 0% mortality, new neurological deficits, 0%, rare cases of postoperative CSF leaks or meningitis, epistaxis or nasal bleeding that happens several weeks out from surgery that requires some cauterization. That happens in rare cases and is a bit more common in acromegaly, patients with acromegaly than patients with non-functioning tumors. And then new hormonal deficits is less than 5%, but we also see hormone improvement with surgery. So overall, surgical remission equals normal IGF-1 by 12 weeks post-op. It could be sooner than that, of course. And a remission is most easily achieved when the tumor is smaller. So microadenomas, or tumors that are smaller than a centimeter, remission rates are 80 to 90% reported in the literature. Macroadenomas, that percentage rate goes down, big range from 40 to 75%. And that success, that rate of remission with tumors, drops in macroadenomas because it correlates with the anatomy of the tumor. How big is that tumor? Is there cavernous sinus invasion? Is there invasion intracranially? That makes total resection more challenging. And up to these tumors are inherently more invasive than non-functioning counterparts. What is the pre-op growth hormone and IGF-1 level? If it's very high, that's going to make a surgical remission lower chance, not impossible, but a lower chance, because that tumor is just, the biology of that tumor might be higher functioning. And then experience of surgeon. How much has your surgeon removed these types of tumors? How comfortable are they from determining normal structures from tumor, normal gland from tumor? And so remission rates after surgery for acromegaly, this is just a figure showing the statistics I just outlined, but in single surgeon, high volume centers reported over many decades, outcomes are pretty similar. Microadenomas have the highest chance of being cured, it drops with macros, and then invasive tumors, the rates of remission drop more. And that is because of invasion, most likely. So there's a classification called the NOSP classification, named after the first author who first reported on these, who decided to classify the relationships of the tumors as it relates to the cavernous sinuses on either side of the pituitary gland. This cavernous sinus area is a vascular channel where the carotid artery runs. It does a little C shape through this area. And then there's within the cavernous sinus and then along the walls, there are cranial nerves traveling to our eyes, to our face for facial sensation. So our eye movements can be affected by these cranial nerves. Our vision can be affected mostly with eye movements, causing diplopia or even eye closure. So double vision or eye closure. And so the grading scale is 0 with no cavernous sinus invasion. So there's a tumor that is just sitting in the cella itself. This is the gland, the optic chiasm up here, the red is the carotid artery, and then the yellow are the cranial nerves traveling. And then grade 1 is that it approaches the midline of the carotid artery. Grade 2 is it goes all the way to the lateral border of that carotid artery in the cavernous sinus. Grade 3A goes past that line. 3B, it goes past that line, but inferiorly, not between the C shape of the carotid artery, but below. And then grade 4, it's entirely 360 degrees encompassing that carotid artery. So this is the NOSP classification, or cavernous sinus invasion, and this can determine resectability. So cavernous sinus invasion is the most common reason for lack of a surgical cure, typically. There's growing evidence, enhanced by our endoscopic technology, for surgeons to have a direct inspection of that cavernous sinus wall and be a little bit more aggressive than surgeons typically were. And so they inspect that medial wall, or the wall that's right next to the pituitary gland, but heading towards the carotid artery on the lateral side. And if they suspect involvement or see frank involvement, resecting that wall. And they have seen that higher rates of remission have been achieved by doing that, and higher rates of gross total resection, even with NOSP grade 4. But with all of our patients, we favor safety much more than we favor a cure. So it's, the carotid arteries there, the cranial nerves are there. Some series report that the remission rates, including macroadenomas, goes up. They report only transient double vision, none permanent, no carotid artery injuries. But these are high volume centers with very experienced surgeons. So I think for aggressive approaches surgically, you want to be at a high volume center, having surgery with a high volume surgeon. It's important for the management team to make sure it's a good patient selection, that they're doing this for the right reason. And intraoperative monitoring can be helpful too. So case number 2 is a 53-year-old man with years of enlarging hands requiring new wedding rings. And he'd bought multiple new wedding rings. They stopped fitting, ultimately seeking workup after he went to his med school reunion and his friends said, "Hey, we haven't seen you in a while. We noticed changes in your facial features." And he'd also noted new type 2 diabetes and joint pain. So he went back home from his reunion and sought medical workup, and his IGF-1 was indeed elevated. He had a normal prolactin, so suspected to be a growth hormone secreting adenoma. And in his MRI, not a very large tumor, but invasive off to the cavernous sinus. Since we're looking at him, this is his right side, invasive to that right cavernous sinus. And so in surgery, it was actually kind of splitting the walls of that medial wall of the cavernous sinus such that I was able to open it up and remove that part extending laterally into the cavernous sinus. And so able to achieve a surgical cure despite the invasion, because it was safe to do so. And so afterwards, he was actually able to get on all the wedding rings and took a picture and sent it to me. So it's an impressive picture. Conversely, recently taken care of a patient, an 81-year-old, whose tumor was picked up because they had significantly rapid cognitive decline. And they presented with this incidental pituitary tumor finding. And the workup was revealing of an elevated IGF-1 and an elevated prolactin, so perhaps a dual secreting tumor. And in this patient, we can see that the tumor is actually wrapped all the way around. It has that grade 4 invasion into the cavernous sinus. So unlikely in an 81-year-old to be aggressive for a surgical cure. And in fact, right now, we're starting on medical management because we don't feel that with his cognitive decline, he's the best surgical candidate at this time, and we'll see how medical management goes. So very different ways of managing things. There are different benefits to medicine versus surgery. So medical remission versus surgical cure, the advantage goes to surgery. Obviously, if you can remove it all, that's the goal. And it's the fastest way to remission as well. However, the risk profile would favor medicine. You're not undergoing a surgical procedure, undergoing general anesthesia. You're not at risk for a CSF leak meningitis. Even though those risks are low, you're still at risk going under a surgery. And then relief of mass effect. If patients have mass effect, if they have vision issues, surgery is really the best and sometimes the only way to achieve improvement. And then from a cost perspective, a surgery, depending on where you live, a 1 to 2 night hospital stay may be in the order of $50,000 to $75,000. Medical costs will total more than that if they're on it for a long term. So the advantage there is to surgery as well. Now, giant and invasive adenomas definitely pose challenges. So surgery is needed. Which type? Should it be staged? Should we use pre-medication? These are still all questions that we're seeking to answer. But this is a large tumor with a lot of intracranial extension, a lot of cellular component, but it goes well beyond the point at which you'd be able to achieve total resection with a transsphenoidal. So these controversies: should patients with acromegaly be treated with medication prior to surgery? Does it improve remission rate? Does it make anesthesia safer? Should patients with surgically incurable tumors even have a surgery if it's not going to cure them? Does it make medication more effective? So these are questions the researchers are still trying to answer. At this time, for pretreatment with somatostatin receptor ligands, there's no strong evidence that says it significantly helps long-term remission rates to pretreat patients. However, it can be helpful. So normalization, sometimes we do see normalization of IGF-1 with the somatostatin receptor ligand therapy and prior to surgery, and it's associated with better outcomes. But this is more likely reflective of the underlying biology of the tumor than a direct effect of the pre-op treatment. So right now, consensus in the field favors use only in select cases, so severe comorbidities that may heighten anesthesia risk. The cardiomyopathy, high output cardiomyopathy that I mentioned, was reasons why we do a pre-op echocardiogram. Significant sleep apnea, where we want to pre-treat to make them help patients have a safer airway prior to undergoing anesthesia. And if it can help with tumor shrinkage in invasive macroadenomas and make surgery more easily to get, or help surgeons get more out with the surgery. So this is one patient with a giant invasive macroadenoma who they did not have vision issues, and so we had some flexibility with time, and due to some life scheduling, we placed them on preoperative somatostatin receptor analog treatment. And we did see some shrinkage, but really a 0.5 centimeter in multiple directions, and this was after 6 doses of lanreotide. But the growth hormone level really didn't change. The IGF-1 level didn't change, or actually went up slightly. So ultimately, we did 2 stage surgeries, and then somatostatin analog management, also cabergoline and radiation, bringing them to remission at this time. So this is an example of the multimodal therapy needed for the larger invasive tumors. Another case. This is a case where this patient was placed on pre-op treatment because he had a large tumor, which I'm sorry that his initial MRI showed didn't have good contrast uptake, but you can see it was invasive. It had this portion going anterior. This is a sideways view of the sella, and there's this portion going above the sella and anterior intracranially. Really on the borderline of maybe also needing a craniotomy to manage. But the tumor actually shrank about 1 centimeter with treatment, and that anterior nodule shrunk down such that I was able to access all of it through a single transsphenoidal. And so the medical management lowered the IGF-1, and then surgery helped it lower, and then helped ultimately the medical management plus surgery achieve remission. There was a small piece near the optic nerve anteriorly that we're still watching that has shrunk down. So is debulking without cure helpful? If we're not curing them, do we need to do a surgery? Multimodal remission is achieved at higher rates with smaller tumor remnants. So yes, surgery is helpful. Also with a lower growth hormone and IGF-1 level. So yes, surgery is helpful. And also it allows for faster symptom improvement if patients have symptoms from the size of their tumor, even if it's not able to be removed. This involves a craniotomy, so an open surgical procedure. This is a cartoon schematic here, and this is a zoomed in area where we see the sella is down here underneath this area where we see the optic nerves and the carotid arteries in red. And so this is a patient with a large invasive growth hormone secreting adenoma with, based on size, a probably lower IGF-1 than you'd expect. So a pre-op IGF-1 of 693, but also a significant bitemporal field cut. And that's actually how he presented. The IGF-1 came after that. The findings of diagnosis of acromegaly came after he'd had the MRI and had his vision complaints worked up. And he had many of the classic clinical findings. And so we performed a bifrontal craniotomy to remove a lot of the frontal tumor, and then an endoscopic transsphenoidal. But there's still tumor that remains. I didn't have to, these are anterior cerebral arteries. These are major arteries controlling functions of our frontal lobes, our movement of our legs. I didn't want to pick tumor off and place him at high risk for stroke. Is he able to be controlled without that aggressive of surgery? Yes. So really, it's combining all the tools in our tool belts. And at our center, we did review our patients with acromegaly greater than a year of data after surgery and at least 2 subsequent clinic visits between 1980 and 2019, with a total of 266 patients. And IGF-1 was normalized in 93% of these patients. For patients not cured with surgery, those diagnosed after 2006 were more likely to achieve remission with medications, with lower rates of radiation or second surgeries compared to patients treated in the earlier era. And that was timed with when we had our growth hormone receptor antagonists come out. So this is generally our clinic schema. Maximum safe surgery, followed by somatostatin receptor ligands, plus or minus growth hormone receptor antagonists, plus or minus cabergoline, still not controlled, radiation, and then repeat surgery is really saved only if necessary. Does a specialized pituitary surgeon improve outcome? The findings are yes, definitely. This is a decades-old paper, but very interesting. This group in Birmingham, UK, looked at their outcomes of remission, weren't happy with them, 54% of remission in micros, 30% with macros, and then actually centralized all of their acromegaly, their surgeries from acromegaly under one surgeon. And then the remission rates significantly improved. And there's been many studies since then to demonstrate this. The volume outcome effect in pituitary surgery means higher volume of doing a transsphenoidal means better outcomes. And this is a look at the nationwide inpatient sample or 20% subsample of the US population, almost 5,500 patients. And you can see if surgeons are only doing 1 transsphenoidal a year, their mortality rates are significantly higher than surgeons doing 8 or more. And same thing with the complication rate. It goes down. The more you do it, the better you're going to be at it. The Pituitary Society defines centers of excellence as as having a surgeon with a preferred case volume of at least 100 pituitary surgical procedures in that center per year. 50 surgeries is considered the acceptable minimum. And they also recommend 3 dedicated pituitary neurosurgeons within that center. 1 dedicated is also acceptable. And then they see that with these are the centers who meet these criteria have higher remission rates and lower complication rates. So overall, the 14th annual 14th consensus group of acromegaly recommends surgery that's safe and effective as a primary treatment for most patients. The primary predictors of surgical remission are tumor size, invasiveness, and experience of the neurosurgeon. Medical therapy is recommended for patients who do not achieve biochemical control or are not great surgical candidates. Radiotherapy we really reserve for patients that have failed or are unfit for or have declined surgical or medical therapy. And Harvey Cushing, the father of how we treat these surgeries, how we began to understand these surgeries. He's back in 1912 in his book, The Pituitary Body and Its Disorders, said, "It is conceivable that the day is not too far distant when our present methods of dealing with the hypophyseal enlargements with scalpel, rongeur, and curette, new as these measures actually are and brilliant as the results may often be, will seem utterly crude and antiquated. And for it is quite probable that surgery will in the end come to play a less rather than a more important role in ductless gland maladies." So surgery has a role now, but who knows where the future heads. And thank you so much again for letting me participate in this day. It's a real honor.